right. Hello. Um, my name is Marcia, and I'm with Christine and Charlene and Yi, and we are doing the stimulant use dependence. We're going to talk about stimulant use. So let me advance it. Hopefully, it'll advance. Oh, there we go. Yay. All right. So, um, stimulant drugs, they belong to a large class of drugs that could include both legal and illegal substances. Stimulants, what they do is they cause like a temporary like alertness and increased attention and feelings of increased energy. And the effects are caused by increased activity in the brain, the central nervous system, because of the use of these stimulants. And what is this? Oh, here, that's one. Okay. So some examples of some stimulants. So some prescribed ones are like medications for ADHD, such as Adderall. And there are some legal stimulants such as caffeine, nicotine, chocolate, and some illegal stimulants such as methamphetamine and cocaine. There's just some examples there. Okay. So caffeine is the most widely globally used stimulant in the whole world. 80% of adults consume caffeine, and then I've got some different foods that have caffeine, and there are different contents of the caffeine listed there. And according to the mental health site that I went to, the consumption of caffeine is actually on the rise. So, all right, so prevalence. So psychostimulants such as methamphetamine and cocaine, the average annual use of stimulants is about 16 million adults every year use stimulants. There was a survey done from 2014 to 2019 about the stimulant use, illegal stimulant use from adolescents, and 22.7% said that they used inhalants. So that's another stimulant. Just you don't have to get street drugs or Adderall. You can actually just sniff inhalants and get that stimulated feeling. Then also I looked on the CDC and I looked at a survey that they did about deaths from overdose from stimulants during COVID. And the CDC said that the death from stimulant overdose was increasing. So from June 2019 to May 2020, it went from 26 to 30% of people who use stimulants actually OD'd on and died from stimulant use. Mm-hmm. Okay, Christine, you're next.
Okay, so stimulant use dependence in primary care is something that each of us need to be worried about. Whether or not we work in primary care or in a specialty clinic, we're going to run into this because so many people do use stimulants. A lot of people won't let the provider know that they're using stimulants. So we need to be aware and ask hard questions. Primary care providers need to ask about stimulants prior to prescribing any other medications because there are a lot of drug interactions that we need to be aware of. And would you mind forwarding the slide?
Absolutely. Sorry.
Polysubstance use is increasing. So a lot of people are using stimulants with opioids, and they're seeing a lot of problems with this. And so that is something that we need to be aware of as providers. And also one thing that was pointed out is that there are a lot of people on stimulants that are dependent upon them, and they don't want to be treated. They want to just keep using them. Okay, so next slide. There is an action phase, and this is talking about stimulants like methamphetamine and cocaine, where people will go long periods without food or sleep. That's called the action phase. And then there's a reaction or recovery phase, and this is where the person is in sheer exhaustion, fatigue. They'll sleep for very long periods, and they'll have extreme hunger. Some of the acute signs and symptoms that you'll see, especially with methamphetamine and cocaine, are hyperarousal, dilated pupils, tachycardia, hypertension, anxiety, euphoria, hallucinations. They'll get spasms of their TMJ muscles, and so they'll grit their teeth and have a lot of pain associated with their TMJs. Insomnia, anorexia, lots of other signs and symptoms as well. Now, with chronic use, you're going to see the tooth decay, gum disease, they'll lose a lot of teeth. People become paranoid, have delusions, hallucinations, they'll tweak. And that's an interesting thing if you've ever seen that. People will pick at their skin and cause lesions. They'll get psychotic symptoms. And a lot of these people will end up with depression. They'll have legal problems and they won't be able to hold down a job because they won't be meeting the requirements for their jobs or social obligations or family obligations. Okay, some of the lab abnormalities. First of all, amphetamine assays are difficult to interpret. You kind of need to be experienced to really figure out what you're doing with that. Before you do any testing, you need to ask about their other medications because you can get false positives if people are taking just regular decongestants like pseudoephedrine, promethazine, lots of other medications can cause a false positive. So something to be aware of before you even bother doing a test for amphetamines in someone's system. Okay, next slide. Some of the labs that we'll want to check if we do know somebody is using and they're having problems, we'll want to look at renal function, look for electrolyte imbalances. And rhabdomyolysis is a common problem with people that have been using high doses of stimulants. So they're causing, basically muscle death. And so we're going to see higher CK levels or myoglobin levels. If the myocardium is impacted and there's ischemia, you're going to see elevation of troponin levels. Okay.
Okay, so for diagnosis of stimulant use disorders, we want to complete a thorough substance use assessment. So this will include just a detailed inventory of the type of stimulant they're using, their frequency, the amount, the consequences that it has on their life, and then also assess their readiness to change. Sometimes they may not be completely ready to change. Sometimes they may want to just improve a little bit or completely quit using the stimulants. We want to also review their past medical and psychiatric history, and then review their family history, as well as psychosocial factors that may contribute to their substance use disorder. And I think with conducting this assessment, it's important to remember to use the motivational interviewing that we've been practicing this semester, just making sure that we don't show any judgment towards them, and then just showing them a lot of love and care, and that we're there to support and help them. All right. Also, the DSM-5 is another tool that we can use for diagnosis. So this allows the clinicians to determine how severe their problem of substance use disorder is. So with 2 or 3 symptoms, that indicates a mild substance use disorder. With 4 or 5 symptoms, it's moderate, and then 6 or more symptoms is a severe. We can also use lab work to support our diagnosis. So the 2 most common are going to be the urine drug screen and a blood drug screen. So some pros and cons with each of those. So with the urine, it's inexpensive, usually readily available, non-invasive. And then you just have to be aware that there could be limited accuracy for risk of a false test if it's being obtained unsupervised. And then for the blood drug screen, it's also inexpensive and it may determine more acute intoxication. So if your patient comes in having symptoms of acute symptoms that Christine had just talked about, some cons is that it is a little bit more invasive and it may not determine past drug use.
Okay, principles of treatment. So there is a model called the continuing care model, and it's based on routine assessment and treatment that is customized to the preferences and needs of the patient. We need to recognize that this is a chronic, often recurring condition. The intensity of treatment should be based on the patient's presentation, what their rating of severity is, how they're responding to treatments, or if they've had any previous history or treatments. Slide. Thank you. Again, patient preferences, location of where they are actually can have a big impact on what kind of care is available to them. And then also, as mentioned, the payer sources, if they're trying to use insurance, that kind of thing can limit what resources they have available. That can be kind of frustrating as a provider. But the overall idea is we need to set goals with the patient. And as mentioned previously, not every patient wants to completely withdraw from stimulant use, and they may not be willing to or capable in some cases. So we kind of have to weigh the ideal abstinence against harm reduction as well and see if we can try to help these patients improve their health. So the first line is psychosocial interventions. Also, that's going to depend on the DSM-5 severity, whether it's mild, moderate, or severe. Oftentimes, these type of interventions will include individual and or group counseling. It could be standard outpatient, or it could be more intensive outpatient therapy, which is just more time, more checkups, more, just like it sounds, just more intensive, just to kind of help keep people on the right track that are maybe having a hard time or have a history of relapse. And then cognitive behavioral therapy, just counseling services can be really beneficial to many, many people, anything from like cigarettes to cocaine use or meth. So that CBT is always a good thing. I just wanted to give a couple of examples. For example, with cocaine use disorder, oftentimes if we're going to do pharmacological treatment, we're going to do something like topiramate first. If that's not working or they need something more or they're relapsing, you can try a long-acting amphetamine, but that would definitely be a second line. For something like methamphetamine use disorder, you would want to do an injectable combination with the naltrexone. That can be kind of expensive, but then you combo that with the bupropion or the Wellbutrin is the brand name daily, and that seems to be really helpful. And I'm not going to get too much into the dosing. You usually start at 25 milligrams, I believe, but I'm not going to get too detailed in there. Slide, please. Thank you.
Oh, all right. So wrapping up with follow-up care, a timely follow-up care for treatment of the stimulant use disorder is critical to reduce negative health outcomes, such as disengagement from the healthcare system and substance use relapse. So I think it was shown that substance use relapse is most common between 7 to 30 days after treatment. Okay, next slide. And then I also think this mostly depends on your work setting. And so for maybe a setting that offers therapy and treatment, this contingency management may be appropriate, where they will conduct urine tests to detect recurrent use. And then there's also a validated saliva test that's now available. And it's recommended that this is conducted at least twice a week at the start of an abstinence program.
Yay.
Thank you.
Thanks so much.